You can sleep 8 hours straight, never wake up once, feel completely rested in the morning, and your brain can still be accumulating the exact proteins associated with Alzheimer's disease while you do it. Not because of your genetics, not because of some disease process you inherited, because of the angle your body is lying at during those 8 hours. That mechanism, what researchers at the University of Rochester first mapped in detail in 2013, has an official name now. And once you understand what it actually does and what blocks it, the position you've been sleeping in for 60 plus years is going to look very different to you. By the end of this, I'm going to give you something called the 3-point lateral reset. 3 physical changes to how you set up your body tonight. They cost nothing and take about 45 seconds to arrange. But to understand why they matter and why 2 out of 3 is not enough, we need to strip this back layer by layer, starting at the surface and working down to what is happening inside your skull while you sleep. I'm Carol. I read the studies, the clinical guidelines, the meta-analyses, the things your doctor doesn't have time to explain during a 15-minute appointment. Then I tell you what actually matters and what you can do about it tonight. Let's go. The first thing you need to understand is why 60 is different, not in a motivational sense, in a mechanical sense. Because the mainstream sleep advice you have been absorbing for decades was largely developed on younger bodies, and the people giving it out did not bother to tell you that the rules change. Between the ages of 30 and 70, the average person loses roughly 30% of the skeletal muscle mass they had at peak strength. That process, called sarcopenia, does not just change how you look or how much you can lift, it changes how your body holds itself up during sleep. The muscular support network that keeps your airway open, that stabilizes your spine against the pull of gravity, that maintains gentle pressure around your digestive tract, it thins quietly over decades. By the time most people reach their mid-60s, the structural scaffolding they were relying on in their sleep, without ever knowing they were relying on it, is meaningfully weaker than it was. At the same time, the cartilage between your vertebral discs has been compressing for 6 decades. Most people over 60 have measurably reduced disc height compared to what they had at 40. The average lumbar disc loses roughly 30 to 40% of its height between age 30 and age 70, according to data published in the journal Spine. That matters because the nerves exiting your spinal column pass through narrowing channels called foramina. When disc height drops, those channels get smaller. Positions that were structurally neutral at 35 can compress nerve roots that were never at risk before. And then there is a third change that hits after 60, one that almost nobody discusses outside of sleep medicine clinics. The tone of the pharyngeal muscles, the muscles that line the back of your throat and hold your airway open against the downward pull of gravity when you are lying on your back, drops significantly with age. In a 30-year-old, these muscles maintain airway patency automatically, without effort. By 65, after decades of subtle atrophy, they are fighting a losing battle against gravity every single night. The body you are sleeping in right now is not the body that developed the sleeping habits you have maintained for decades. That mismatch between old habits and changed biology is where the damage lives. Let's strip away the first layer, the airway. When you lie on your back, the supine position, gravity pulls the base of your tongue and the soft tissue at the back of your throat directly downward toward the back of your neck. In a young person with strong pharyngeal tone, the muscles resist this pull without conscious effort. In someone over 60 with reduced tone and narrowed airways due to tissue thickening and fat redistribution in the neck, that pull wins more often. The result is a partial or complete collapse of the upper airway. Partial collapse creates snoring. Complete collapse creates an apnea, a breathing pause lasting anywhere from 10 seconds to over a minute, sometimes longer. Here is what most people misunderstand about sleep apnea. They think of it as a snoring problem, a quality of life nuisance. Their partner nudges them, they roll over, breathing resumes, the night continues. What is actually happening during those pauses is something your cardiovascular system would classify as a crisis. Each apnea event drops your blood oxygen saturation, your SpO2, from a healthy 97 or 98% down to levels that in a waking person would trigger emergency care. People with moderate to severe untreated obstructive sleep apnea regularly drop to 80% or lower, and they do this dozens of times per night. Each time oxygen falls, the brain detects the shortfall and fires a micro-arousal, a brief awakening too fast to reach consciousness. You will never remember it. Your heart rate spikes, your blood pressure surges, your sympathetic nervous system, the architecture designed for escaping predators, activates fully. You think you slept through the night. Your nervous system ran emergency drills every 3 to 7 minutes for 8 hours. But beyond the cardiovascular consequences, which I'll get to in a separate layer, there is a cognitive dimension to this that is consistently underreported. When oxygen saturation drops repeatedly during sleep, it does not just stress the heart, it stresses the brain. The prefrontal cortex, the hippocampus, and the regions responsible for executive function are acutely sensitive to hypoxia, to oxygen shortfall. A 2012 study published in the journal Sleep found that people with moderate to severe obstructive sleep apnea showed measurable reductions in hippocampal volume, the brain structure central to memory formation, compared to matched controls, not older people, not people with other risk factors, people whose primary distinguishing variable was interrupted overnight oxygenation. This is not damage that requires years to accumulate visibly. Research from Oxford using functional MRI has shown that white matter changes, microstructural damage to the brain's connective tissue, are detectable in people with untreated sleep apnea even within the first year of diagnosis. The brain is not shielded from the oxygen dips. It is the primary target. According to estimates from the sleep research community, somewhere between 50 and 60% of people with diagnosed obstructive sleep apnea have what is classified as positional obstructive sleep apnea, meaning their breathing events are at least twice as frequent when they are on their back compared to their side. That is a majority. And among people over 60 who have never been formally diagnosed but who snore regularly, the positional component is even higher because reduced pharyngeal tone, not structural obstruction, is the primary driver. What this means for you right now: if you are sleeping on your back tonight and you are over 60, your airway is almost certainly narrower than you think, your oxygen levels are almost certainly dipping more than you know, and your brain is experiencing some degree of intermittent hypoxia that you will never feel happening. That is not a future risk. That is a description of your current nights. But the airway is the surface. Strip that back, and underneath you find the spine. We have been told for decades that sleeping on your back is actually the best position for spinal health. Neutral spine, even weight distribution, no asymmetric pressure on the joints. Physical therapists recommended it. Mattress companies spent enormous money reinforcing the idea. It sounds completely reasonable. Here is what that recommendation is missing. It was developed without distinguishing between the spine of a 40-year-old and the spine of someone over 60. A young adult lying flat on their back does achieve something close to a neutral lumbar curve. Their disc height supports the architecture. Their paraspinal muscles, the thick bands running alongside the spine, maintain stability even while relaxed. Their facet joints, the small paired joints at the back of each vertebral segment, are well cushioned. After 60, all three of those factors have shifted. Disc height loss means the lumbar spine naturally adopts a greater inward curve when lying flat, increasing compression on the facet joints, which are simultaneously the primary site of osteoarthritic change in older adults. You are sleeping on the most arthritic joints in your back, and gravity is loading them continuously for 8 hours. The psoas muscle compounds this. The psoas is the deep band of muscle connecting your lumbar vertebrae to the top of your femur. In the supine position, the psoas sits at its natural resting length, which in most sedentary adults over 60 means it is already shortened from years of prolonged sitting. 8 hours of back sleeping reinforces that shortening. By morning, the psoas is tighter than when you lay down, not because you did anything wrong during sleep, because you maintained a position that requires nothing of it for 8 consecutive hours. The stiffness you feel in the lower back on waking is commonly attributed to the mattress or to aging. Often, it is the psoas telling you where it spent the night. There is also the spinal stenosis connection, which matters more as this population ages. Lumbar spinal stenosis, a narrowing of the spinal canal that compresses nerve roots, affects a substantial portion of adults over 60. In the supine position, the lumbar spine extends backward, physically reducing the already narrowed canal diameter. People with stenosis who switch to side sleeping with a pillow between their knees, maintaining a slight forward flexion at the hip, are essentially prying the canal open a few critical millimeters by changing the lumbar curve geometry. This is why the physical therapy literature on positional management for stenosis almost universally recommends lateral sleeping. It is not comfort preference, it is geometry. Now, stomach sleeping. About 7% of adults sleep this way, and every one of them is doing structural damage they cannot feel accumulating. Prone sleeping requires the cervical spine to rotate nearly 90 degrees to one side for 8 hours because the face cannot remain downward without suffocating. That sustained rotation loads every disc, facet joint, and nerve root on the compressed side of the neck for the entire duration of sleep. The vertebral arteries, which supply blood to the posterior brain, including the cerebellum and the brainstem, run through small openings in the cervical vertebrae called the foramina transversaria. Sustained rotational compression can reduce flow in these arteries during sleep, a mechanism that has been proposed as a contributing factor in some cases of vertebrobasilar insufficiency in older adults. What makes this particularly insidious is the asymmetry it produces over time. When radiologists read cervical MRI scans, they can sometimes identify which side a patient habitually rotates toward in sleep, because the asymmetric facet degeneration and disc narrowing on the compressed side is that consistent. Decades of prone sleeping do not just create discomfort, they write the pattern into the cartilage. Now let's go deeper. Under the spine, we find the digestive and metabolic layer. The lower esophageal sphincter is a ring of muscle at the junction between the esophagus and the stomach. Its job is to stay closed when you are not swallowing, preventing stomach acid from traveling upward. In younger adults, this sphincter maintains strong resting tone. By the time most people reach their 60s, that tone has measurably declined, partly from aging, partly from years of dietary patterns, and partly from the gradual relaxing effect of increased intra-abdominal pressure in people who have gained central weight over the decades. The consequence is a higher baseline rate of nighttime acid reflux, and sleep position determines exactly how bad that reflux gets. When you lie on your back, the stomach and the esophageal junction are at roughly the same horizontal plane. Gravity, which would normally drain acid back downward when you are upright, is no longer providing that assistance. When you then lie on your right side, the anatomy gets worse. The stomach, which sits to the left of center in the body, tips so that the valve connecting it to the esophagus becomes the lowest point of the stomach's fluid pool. Acid flows directly toward the opening. When you lie on your left side, the geometry inverts completely. The stomach's natural curvature means acid pools at the fundus, the rounded upper portion, which is now the lowest point. The esophageal junction is above the acid level. Gravity is pulling the contents away from the valve rather than toward it. A study published in the Journal of Clinical Gastroenterology measured esophageal acid exposure across sleeping positions and found that right-side sleeping produced acid exposure times roughly double those of left-side sleeping, not slightly elevated, double. That is the difference between two positions most people treat as interchangeable. This matters beyond the discomfort of heartburn. Chronic nighttime acid exposure, much of which is silent, producing no burning sensation because the esophageal tissue partially adapts to the irritation, causes cumulative cellular damage to the esophageal lining. That damage, sustained over years, can progress to a condition called Barrett's esophagus, a precancerous change in the cell type lining the lower esophagus. The National Cancer Institute estimates that people with Barrett's esophagus face a 30 to 125 times higher risk of esophageal adenocarcinoma compared to the general population, depending on the grade of cellular change. Most people developing that cumulative damage are not waking up with dramatic heartburn. They are having silent nocturnal reflux, a category that gastroenterologists have documented extensively using pH monitoring studies, in which patients wearing esophageal pH probes during sleep register significant acid exposure events, while reporting no symptoms the following morning. The tissue damage is not announcing itself, it is accumulating invisibly. Left side sleeping reduces your esophageal acid exposure tonight, tomorrow morning, not after 6 weeks. The mechanism is immediate and the geometry is simple. You are either tilting the acid toward the valve or away from it. That choice is made when you set up your pillow. Now, let me get to the cardiovascular layer, because this is where most mainstream sleep advice is genuinely incomplete in a way I find persistently baffling. The dominant frame for blood pressure in popular health advice is daytime. You monitor it in the morning before your coffee, you take your medication, you reduce sodium. The implicit assumption embedded in most cardiovascular guidance is that sleep is in neutral state, the heart resting, the vessels at peace. It is not neutral. And what happens to blood pressure during sleep is not peripheral to cardiovascular health. It is central to it. In healthy adults, blood pressure follows a circadian pattern called nocturnal dipping, a 10 to 20% reduction during sleep compared to daytime averages. This nightly reduction is not simply a byproduct of being inactive, it is a repair window. When arterial wall pressure is lowest, the endothelium, the single-cell thick inner lining of the blood vessels, gets the sustained low-stress environment it needs to resolve inflammation, repair microdamage from the day's pressure fluctuations, and maintain its antithrombotic properties. The endothelium is not passive plumbing. It is an active hormonal organ, and it is working hardest when blood pressure is lowest. Non-dippers, people whose blood pressure does not drop by at least 10% during sleep, lose this repair window. A 2018 analysis published in the journal Hypertension found that non-dipping status was associated with approximately a 40% higher risk of major cardiovascular events, including heart attack and stroke, independent of average daytime blood pressure. What you measure in the morning is not the full story. What happens while you sleep may be more predictive. The leading cause of non-dipping status in adults over 60, outside of kidney disease, is obstructive sleep apnea. Each apnea event produces a sympathetic surge, cortisol and adrenaline, that spikes blood pressure upward. In someone having 40 events per night, the nocturnal dip is effectively abolished. The endothelium never gets its repair window. The arterial walls accumulate low-grade inflammatory damage across years of disrupted nights, and none of it is visible until it becomes a clinical event. There is also a second mechanism operating at the level of the vagus nerve. The vagus is the longest nerve in the body, running from the brainstem down through the neck alongside the carotid arteries branching into the heart, the lungs, the digestive system. It is the primary conductor of parasympathetic activity, the rest and recovery mode. Heart rate variability, which cardiologists use as a direct index of cardiovascular resilience, is largely a measure of vagal tone. Higher heart rate variability means the heart is responsive to changing demands. Lower heart rate variability correlates with cardiovascular rigidity and increased all-cause mortality in multiple large prospective studies. Certain neck positions during sleep, specifically the hyperextension that occurs in back sleeping when pillow height is wrong, or the lateral rotation in stomach sleeping, can create mechanical compression along the vagal pathways in the neck. Not enough to cause acute symptoms, enough to reduce the quality of vagal signaling during the hours when it is supposed to be most active. You are dampening your own parasympathetic recovery every night your neck is in the wrong geometry, not because anything is structurally wrong with your vagus nerve, but because the physical channel it runs through is being mechanically pinched by your pillow. If you are starting to feel like there are a lot of moving parts here, I understand that. My husband felt the same way when we were working through this after his aneurysm. You get all this information at once, and it feels like a pile of evidence against choices you made without knowing they were choices. That tipping point into overwhelm is exactly where most people close the tab and do nothing, which is the only outcome worse than doing the wrong thing. Here is where I want to be honest with you for a second. I had read about sleep position research before my husband put a structure around it. I knew about the lateral sleeping data, about the Jerd mechanics, about the vagus nerve connection. I had the bookmarks. I had the mental agreement that I should change how I slept, and I still didn't for a couple of years, because behavior that happens while you are unconscious requires a different kind of intervention than behavior you can choose with your prefrontal cortex in the morning. My husband spent months turning what we had learned into something actually usable. He'd had the health scare. He had the motivation to read deeply and build something that didn't just explain the science but gave it daily structure. Something that takes under 5 minutes to use and doesn't ask you to hold the whole architecture in your head at once. The Noon Reset Protocol is the 30-day guide he built. It's structured around Nobel Prize research on circadian biology, the same circadian framework that governs the sleep timing and nocturnal repair windows I've been describing. 2 pages a day, 1 page of science that explains what your body is actually doing, 1 page of tracker so you can see the pattern building, and it's organized into 4 phases: adaptation, activation, optimization, acceleration, because the timeline of biological change is real, and you need to know what to expect in week 1 versus week 3, or you'll quit on day 4 convinced it isn't working, when what you're actually experiencing is the adaptation phase doing exactly what it's supposed to do. He also built in 25 breakfast meal ideas with exact protein counts, because the first meal after the fasting window shapes your insulin and cortisol curve for the rest of the day. And if you get that wrong, the whole downstream architecture suffers. What you eat when you break your fast matters more than almost any other food decision you make. The guide is through the link in the description. Less than a restaurant meal. The fact that it took me 2 years to use something that was sitting in my own house is, in retrospect, genuinely funny and also slightly mortifying. Okay, the deepest layer. This is what I have been building toward, and this is the mechanism I want you to remember above everything else in this video. In 2013, a research team at the University of Rochester, led by neuroscientist Macon Nedergaard, published a paper in the journal Science that changed the fundamental understanding of what sleep is actually for. Not rest, not memory consolidation, though both of those things are real. The primary purpose of sleep that this team identified is waste removal. They discovered what is now called the glymphatic system, the brain's dedicated overnight cleaning infrastructure. During waking hours, neurons are metabolically active. They fire electrical signals, consume glucose, and produce cellular byproducts. Two of those byproducts are proteins, beta amyloid and tau. Both are normal metabolic products, and both, when they accumulate in brain tissue over time, rather than being cleared, are directly implicated in Alzheimer's disease and frontotemporal dementia. Beta amyloid forms the plaques between neurons. Tau forms the tangles inside them. Together, they represent the two primary pathological signatures of Alzheimer's pathology. Here is why the brain cannot clear these proteins during the day. The interstitial space, the narrow gap between brain cells, is too compressed during waking hours when neurons are swollen with metabolic activity. Cerebrospinal fluid, the clear liquid bathing the brain and spinal cord, cannot flow through the tissue in sufficient volume to flush these spaces. The cleaning trucks cannot navigate the congested streets. During sleep, something structurally remarkable happens. Glial cells, the support cells surrounding neurons, shrink by approximately 60% in volume. The interstitial channels widen dramatically. Cerebrospinal fluid rushes through these expanded pathways like water through a suddenly open sluice gate, carrying beta amyloid and tau out of the brain tissue and into the dural sinuses, where they are transferred into venous circulation and eventually processed by the liver. The Nedergaard group subsequently showed in the Journal of Neuroscience in 2015 that this glymphatic clearance is not the same across all sleeping positions. In a study measuring glymphatic transport efficiency across supine, prone, and lateral positions in rodents, lateral sleeping produced significantly more efficient waste clearance than supine. The mechanism is consistent with what we know about how cerebrospinal fluid dynamics are influenced by body orientation and intracranial pressure gradients. In human research, the connection between sleep disruption and amyloid accumulation is now well established. A 2018 study from the National Institutes of Health used PET scanning to measure amyloid burden in the brains of healthy adults before and after a single night of sleep deprivation. One night, the researchers found measurable increases in amyloid accumulation in the hippocampus and thalamus, two regions central to memory and consciousness, following that single disrupted night. This is not a decades-long risk accumulating at an undetectable rate. It is a process that is either happening or not happening in your brain every time you lie down. A 2019 study published in Science by Holth and colleagues showed that slow-wave sleep, the deep, restorative sleep stage that is disproportionately reduced by sleep apnea microarousals, is specifically when tau clearance is most active. Not REM sleep, not light sleep, the deep stage that back-sleeping-induced apnea most reliably destroys. Now pull all of this together. If you are sleeping on your back and you are over 60, you are in the position where glymphatic transport is measurably less efficient. You are almost certainly experiencing some degree of positional airway narrowing that is fragmenting your slow-wave sleep and reducing your time in the stage when tau clearance peaks. And you are doing this every night, compounding quietly, producing no symptoms that would alert you that anything is wrong. This is the invisible villain I have been constructing throughout this entire script. It is not dramatic, it does not hurt. You wake up and feel fine. But the cleaning cycle ran at partial capacity, and the next night it runs at partial capacity again. Over years, the proteins that are supposed to be cleared accumulate instead, and they do it so gradually that by the time any cognitive change is detectable, the structural damage has been building for over a decade. I want to be precise here because precision matters. The research does not prove that back sleeping causes Alzheimer's. Human studies on glymphatic efficiency and sleep position are still in relatively early stages, and drawing a straight causal line from a sleep position to a specific disease outcome overstates what we know. What the evidence does establish clearly is this: glymphatic transport is most efficient in the lateral position, slow-wave sleep is critical for tau clearance, positional sleep apnea is the primary driver of slow-wave disruption in older adults, and positional sleep apnea is directly caused by supine sleeping. You are not required to fill in the gaps with speculation. The chain of mechanism is there. Here is the three-point lateral reset. 3 changes, all 3. The mistake most people make is treating 2 out of 3 as close enough. It is not close enough, and I will tell you specifically why at the end. Point 1 is the head anchor. The most common reason people who try to switch to lateral sleeping migrate back onto their back by 3 in the morning is pillow geometry. On your back, a flatter lower pillow bridges the short distance from mattress to the back of your skull. When you roll to your side, the distance your pillow must bridge becomes the width of your shoulder, typically 4 to 6 inches more. If you use the same pillow on your side that you used on your back, your neck tilts downward toward the mattress. That downward tilt creates cervical compression, puts mechanical strain on the vagal pathways in your neck, and, crucially, is uncomfortable in a way your body registers subconsciously and resolves by rolling away from. You do not wake up to make this choice. Your body makes it below the level of consciousness at around hour 2 of deep sleep. The fix is a firmer, higher pillow for side sleeping. Your ear should sit directly above your shoulder. Your cervical spine should be horizontal, no tilt toward the mattress, no tilt away. If you cannot achieve this with your current pillow, fold a firm pillow in half, or stack 2 medium pillows. The geometry must be correct or the position will not hold. Point 2 is the knee bridge. When you lie on your side, the top leg wants to fall forward across the bottom leg, rotating the pelvis. This pelvic rotation does 2 things simultaneously. It pulls the lumbar spine out of its neutral curve, increasing facet joint compression in exactly the way I described earlier, and it creates enough low-grade discomfort in the hip and lower back that the body, again below the level of conscious awareness, abandons the position. A pillow between the knees prevents this rotation. It maintains hip alignment, keeps the pelvis neutral, and removes the rotational torque from the lower spine. For anyone with lumbar stenosis, This pillow is not optional. It is what maintains the slight forward flexion that keeps the spinal canal open. Multiple randomized trials in physiotherapy literature have confirmed that lateral sleeping with a knee pillow produces significantly lower back pain scores than lateral sleeping without one, even in people who felt their lateral sleeping was already comfortable. Point 3 is the side anchor. This is the point people most reliably skip, and skipping it makes points 1 and 2 nearly irrelevant over the course of a full night. Sleep position is encoded in procedural memory, the same deep automatic system that runs walking, driving, and typing. It does not respond to conscious intention. You cannot decide to stay on your side any more than you can decide to remain at a specific point in a dream. To interrupt the automatic return to your habitual supine position, you need a physical cue your proprioceptive system can detect in the dark, something that creates enough resistance when your body begins rolling backward that a shallow arousal redirects the movement without waking you. A rolled towel secured with a belt, a firm cylindrical pillow placed against your lower back, or one of several commercially available sleep position trainers all work on this principle. When the body encounters the physical barrier during the roll, it registers the resistance and self-corrects. You wake up on your side, not because of any conscious effort you made, but because you made the unconscious alternative physically inconvenient. Left side is the preference for most people over 60, specifically because of the acid reflux geometry I described. The left lateral position places the esophageal junction above the stomach acid level. If you have a cardiac history and your cardiologist has advised against left side sleeping, which applies to certain people with advanced heart failure where the position increases preload, then right side sleeping is still vastly better than supine for airway, spinal, and glymphatic reasons. Bring this up with your physician, but for the vast majority of people over 60 with no specific cardiac contraindication, left side is where the geometry works in your favor across the most systems simultaneously. The common mistake that invalidates the entire protocol is completing point 1 and point 2 while skipping point 3, then concluding after 4 days that lateral sleeping is uncomfortable and abandoning it. What you experienced in that scenario was not lateral sleeping. It was lateral sleeping with correct cervical alignment and correct hip alignment, but without the proprioceptive anchor that prevents your procedural memory from overriding both during deep sleep. You woke up on your back, felt stiff, attributed it to the new position, and went back to what was familiar. The stiffness was the supine return. The new position never got a fair test. The 3-point lateral reset requires about 45 seconds of setup before you lie down. A pillow that fills the shoulder-to-ear gap, a pillow between the knees, a rolled object against your lower back, all three before you lie down, not after you are already drowsy and assembling bedding, feels like surgery. The biology I've described in this video, the airway collapse, the spinal loading, the acid pooling, the endothelial repair window, the glymphatic cleaning cycle, none of it is new in the sense of being recently discovered. The glymphatic paper is over a decade old. The acid reflux position data is older than that. The spine research goes back further still. What is new, or at least what is newly visible to me, is how efficiently all of this information stayed out of general health conversations, while an enormous amount of attention went to supplements, diets, and devices, most of which operate on mechanisms far less well supported than the simple geometry of how you orient your body for 8 hours every night. I do not find this enraging anymore. I mostly find it interesting in the way a slightly absurd situation becomes interesting once you stop expecting it to be rational. The information was there, it was in the journals, nobody put it in a format that made it easy to act on. And so most people over 60 are sleeping through the nightly cleaning cycle they cannot afford to miss, in a position that is quietly loading the exact biological systems that become most vulnerable with age, and waking up every morning feeling fine, until one day they don't. If you are starting the 3-point lateral reset tonight, comment left side below so I can see who is actually doing this. Then subscribe. because next week I am going into something even the sleep medicine community is only beginning to take seriously: what the timing of your last meal does to glymphatic efficiency, and why the window between eating and sleeping may matter more than anything you ate.